Fantastic. All right. Hi, Mary. My
Hi,
name's Kate.
Kaylin.
I don't know if we've met before, but if not, I am the clinical nurse specialist for behavioral health here at St. Joe's, Oakland. And
Nice to meet you. And
this,
congrats on the baby.
oh gosh, thank you so much. She's a lot of fun.
I'm sure she is.
So we will be doing a NCLEX behavioral health focused review today. Um, and if there's, and I want to make this very fluid. So if there's areas that you feel like you can use, you know, like areas that maybe I didn't cover or areas that you specifically know that you feel like we could give a little bit more information on, please just let me know and we can cover that because I kind of made a little bit of an outline of our major behavioral health diagnoses, especially the ones that involve medication management. And then we'll cover after that, we'll kind of cover other behavioral health diagnoses that focus more on therapeutic nursing communication. At least that's how I foresee the NCLEX type questions covering them. And then we can go into some practice questions. Do you
Okay.
feel like that would be a good review or a good layout for NCLEX style testing?
Yeah, perfect. Yeah, that sounds good.
Okay, great. So first we'll talk about the just in general, like mental health review in regards to the NCLEX. And I think first what we want to look at are the style of the questions. We always want to focus on safety. If it's a so when you read the NCLEX question, if it's a question that revolves around safety, the answer, or I guess when you're looking at prioritizing your answers, or when the NCLEX question says, pick which is most important, or what is the priority nursing intervention. Um, when we're looking at psych mental health, safety is always going to be a top priority. And next, which I think this is kind of in general with NCLEX, but next is going to be our nursing process questions. So looking at assessment first, that nursing assessment piece versus jumping in and providing intervention. We're also going to talk about like positive and negative psychiatric symptoms. Those can come up in a decent amount in the NCLEX and psych questions. The DSM-5, I don't know if you're familiar with that term, but the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, and version 5, that is what we currently use. So I just wanted to call that out in case you weren't familiar what the DSM-5 is. I've seen that in some of the NCLEX psych practice questions, and it's what we use as for diagnosing and categorizing mental health diagnoses. Were you familiar with that? Have you heard that term before?
Yeah, yeah.
Okay, great. What else? Just in general with behavioral health and NCLEX style questions, we always want to look for the least restrictive alternative. So when we're planning interventions for a client, specifically a client who has potential for violence or is exhibiting violent behavior, we want to implement the least restrictive alternative. So restraint should only be used as a last resort after all other interventions have been unsuccessful, and when the client is clearly at risk of harm to self or others. I also wanted to point out just kind of a basic overview of psychiatric nursing interventions. We want to recognize manipulative behaviors, implement setting limits for the clients. That's another thing you might see in the NCLEX, if it's a psychiatric based question, they might use the word client or recipient instead of the word patient. And that might be all across the board on the NCLEX, I'm not sure, but specifically with psych questions,
Hmm.
uh, they might use that term instead of patient. So just to be familiar with that. But when we have, when we're dealing with patients with psychiatric diagnoses, we want to recognize manipulative behaviors, make sure we're doing limit setting, setting limits for them, not arguing or bargaining or trying to reason with those individuals. We just want to state the limits and the expectations. We want to provide positive reinforcement for non-manipulative behaviors. Help the client to recognize that he or she must accept the consequences of his or her behaviors and refrain from attributing them to others, and to help the client identify positive aspects about themselves. When looking at NCLEX style questions, we want to consider nursing diagnosis. So our big ones are going to be risk for injury, risk for violence, potentially like a nutritional imbalance that could apply to manic patients, to patients with anorexia or bulimia, disturbed thought process, disturbed sensory perception, impaired social interaction, and insomnia. Those are going to be common nursing diagnoses that go hand in hand with psych mental health nursing. So we can kind of go into talking about our different psychiatric diagnoses. A big one is going to be psychotic disorders, and that is going to be schizophrenia. Now, Marianne, in your experience with the NCLEX or in the past, or even in preparations for, did you feel like do you feel like schizophrenia, bipolar disorder, depression, and anxiety were your main psychiatric topics in the NCLEX, or did you feel like it was kind of veered more towards like PTSD, conversion disorder, like kind of those things?
I know I remember mostly like psych symptoms were on my exam. Like positive schizophrenia symptoms was
Okay.
on there. I remember seeing that. Word salad or whatever, word salad was like, it was mostly symptoms was on there, which I was thinking mostly like more drugs would be on there, but I remember seeing more symptoms than anything.
Symptoms. Okay. So,
oh, and I saw like OCD disorder was on there. Yeah.
okay. Okay, very good. So our psychotic disorder of schizophrenia, that is going to be a main in life, in nursing, in hospital care. I think the statistic is like 1 in 100 people is diagnosed with schizophrenia. So it is a common psychiatric disorder that you will encounter in the hospital. So I would assume that on the NCLEX that there will be, a few questions regarding schizophrenia. In regards to nursing diagnosis, schizophrenia, you're going to look at, of a client with schizophrenia, you're going to look at disturbed thought processes and risk of suicide. There is a high risk of self-harm with individuals who have schizophrenia. And to diagnose somebody with schizophrenia, the individual has to have 2 or more of the following symptoms: delusions, hallucinations, disorganized speech, catatonic behavior, negative symptoms with social occupational dysfunction for at least 6 months. So that kind of touches on some of those positive symptoms that you mentioned and the negative symptoms. So positive symptoms would be believing things are around them that are not. So your delusions or hallucinations. The difference between delusions and hallucinations: delusions are false personal beliefs, grandiose, thinking that they're thinking things about themselves, like thinking they're the king of Peru when that's not true, or having persecutory thoughts, thinking that somebody's always out to get them, having Hallucinations, on the other hand, so delusions are like a false personal belief, whereas hallucinations are the experience of seeing or feeling or touching things that aren't actually there. So hallucinations are more, they can fall into categories of auditory, visual, tactile. So seeing somebody that's not there, or hearing the voice of somebody that is not there, or feeling things. So like they could, an individual with schizophrenia could hallucinate that there are bugs crawling on them. That would be a tactile hallucination. Um, Disorganized speech, that can be that word salad that you mentioned. Um, there's a few other forms of disorganized speech that go along with schizophrenia, like speaking in a way where things are always rhyming. Also speaking in a way where their disorganized speech pattern could kind of like loosely have like very like loose associations and all somehow connect together. Like an individual with schizophrenia might start talking about one thing, and then the next sentence will kind of loop around to come back. How do I'm trying to think about this. It's probably easier to give an example.
Would that be under the negative symptoms then? So the positive is delusions and hallucinations, and then did you already mention the negative symptoms?
So negative symptoms are going to be like negative symptoms would be when an individual is more recluse. So when an individual is not verbally responding to you, who's becoming mute, who is
Okay.
negative symptoms would also be like a decrease in activities of daily living. So if they're not taking care of themselves anymore, like if they're not showering, not, like staying in their home, not coming out of their home, those are going to be your negative symptoms of schizophrenia.
Does flight of ideas fall under like is that with positive symptoms?
Yes, positive symptoms. So a way to think about positive versus negative, I guess, do you remember like learning about Pavlov's dogs and how the positive reinforcement was reinforcement, like positive reinforcement can still be something bad, right? So positive reinforcement can still it's anything that's added, anything additional. Whereas negative symptoms or negative reinforcement is going to be um, anything that falls under stimulating or under the normal. So negative symptom would be more like if the person completely stopped going to work because they could not, partake in their occupation any longer. Um, Negative symptoms is going to be when they're not taking care of themselves anymore, when they're not showering, not paying their bills, um, not able to do those quote unquote like normal things that they were able to do before. That shows that their schizophrenia is worsening.
Okay.
Does that make sense?
Yeah.
Okay. So negative symptoms would also be like a flat affect, when they have no emotional reaction to any situation, having apathy, having deteriorated appearance, anhedonia, or lack of interest in anything, in things that normally brought them interest, and doing kind of interesting posturing. So like that catatonic posture, or sometimes people with schizophrenia do like they can become very rigid. That is all going to be your negative symptoms.
So what you just described, I feel like I've seen like a mixture of both in patients, like they're muted, they
Yep.
don't speak to you, but then again, I've seen patients where they like pace back and forth and
Mm-hmm.
are like talking to themselves,
Yeah,
that disorganized thinking at the same time. Would that be under like negative symptoms as well that they're experiencing? Because like the talking to themselves, um, would that be part of the negative symptoms, or is that more of like a positive symptom?
that is more of a positive symptom. So when they're here, so delusions, hallucinations, and any of that verbal disorganized speech or echolalia where they're repeating back things that you say, kind of like parroting.
Yeah.
Um, that is all going to be positive symptoms. And the
Okay.
negative symptoms are going to be exactly what you described, that posturing, that catatonia, that muteness. Um, and people can experience a range of positive and negative symptoms with who have schizophrenia, and it can they can wax and wane. So you might see them displayed in a patient, both positive and negative symptoms.
Okay.
Some predisposing factors, so things that can make somebody, um, more likely to have developed schizophrenia. And this is you're gonna see this commonly across all, across multiple, schizophrenia, bipolar disorder, depression, anxiety. There's not one thing that causes this. So it's a mix of a combination of influences, genetics, biochemical influences, the way that the neurotransmitters in the brain react differently in an individual, anatomical abnormalities in the brain. So some people have like their prefrontal cortex might be a little different, or their white matter might be a little different. There's sociocultural factors that can contribute to the development of schizophrenia, and stressful life events. The stressful life events and the coping skills, that really tends to be um, a big factor involved in all different mental health diagnoses.
Okay.
Treatment for schizophrenia. We are going to look at psychotropic medications. So with schizophrenia, I feel like this is kind of one that on the NCLEX they might ask about the different medications for. So you want to just be familiar with your different and your antipsychotic medication. So antipsychotics are going to be your schizophrenia treatments. Um, you have first generation antipsychotics, which are your typical antipsychotics, and then you're going to have your atypical antipsychotics. Um, third, first generation antipsychotics, those are going to be like your Haldol, your phenothiazine, and those affect dopamine. So schizophrenia, I think a good way to categorize things in your brain too when thinking about mental health medications, and um, is going to also be incorporating like what neurotransmitter goes with that goes with the medication that treats schizophrenia, or same with bipolar disorder, depression, etc. Because it can help. You know how sometimes the NCLEX will ask like about a medication and then about like side effects of that medication.
Yeah.
If you can categorize which neurotransmitter its effect that the medication is targeting, I think sometimes that can help eliminate or narrow down some of the test question answers. So antipsychotics are going to be affecting dopamine, and some side effects that come with antipsychotic medication are going to be your extrapyramidal symptoms. Have you ever seen those or heard of those before?
Yeah.
So that's going to be those like weird those odd tongue movements, abnormal like facial twitching, and it can also translate down to like leg shaking, arm shaking, posturing, those kind of things, which are all due to the effect of dope, like affecting or messing with the dopamine in the brain. Antipsychotics can also precipitate neuroleptic malignant syndrome. So a patient who has schizophrenia who is taking antipsychotics, can develop neuroleptic malignant syndrome. And that is a life-threatening side effect. Neuroleptic malignant syndrome, it's going to be how you're going to know if your patient has neuroleptic malignant syndrome or NMS is going to be they're going to be have a fever, they're going to be tachycardic, they're going to be hot, and eventually they're going to develop into like having altered level of consciousness, and that's something that we need to intervene at very quickly. And we're going to discontinue the patient's the provider is going to discontinue the patient's antipsychotics at that time. I feel like that's one that typically is going to be on the NCLEX is going to be like patient has a history of schizophrenia and is taking antipsychotics. They're presenting with fever, tachycardia, and diaphoresis, and now have altered mental status. What does the nurse expect? Something. It's going to be the neuroleptic malignant syndrome. Antipsychotics also lower the seizure threshold. So I think that's an opportunity for an NCLEX question to look at risk for seizure or monitoring these patients for seizure activity. Else? The atypical antipsychotics or your second generation antipsychotics, they can have some anticholinergic effects. So you can have that dry mouth that can come with some of them. So that's something, a teaching point for nursing is making sure that the patients are aware of that. Dry mouth, blurred vision, constipation, urinary retention, tachycardia. Another reason, or a reason that patients are being treated with antipsychotics sometimes stop their treatment is going to be because of the weight gain. Some antipsychotic medications can cause some weight gain, and that is another teaching point that nursing can implement, is teaching about those things proactively to hopefully help the patient be more medication adherent to the regimen. Treatment outside of medication can also include individual and group therapy, family therapy, milieu therapy, and behavior therapy. Do you have any questions about the different types of therapies that can be provided, or do you feel like you kind of understand what each of those entails?
I think what I have seen in the while I do questions is that let me find it. It's like electroconvulsant therapy, I think.
Yeah. So electroconvulsive therapy, that is going to be a second line treatment for depression. So depression, our first line treatment outside of like psychotherapy and like individual therapy with depression, we're going to treat depression with medications. And what we're also going to do with depression, or if the medications are not working, so if a patient has treatment or medication resistant depression, and they're still having symptoms of depression, and they can get consulted for electroconvulsive therapy. And what electroconvulsive therapy is, which we actually, just for information purposes, we do ECT at St. Joe's Oakland. It's pretty cool. Dr. Jamil does it. And what it is the patient goes down to the like the OR area, to a procedural area, and they get little electrodes put on their head, and a grand mal seizure is induced, which then helps treat the depression. So with electroconvulsive therapy, they'll have a regimen, like they'll get 5 to 7 ECT treatments. They'll get small doses of electric current applied to the exterior of their head, which will induce a seizure, and it helps to decrease some symptoms. So that's kind of a cool thing. It's a cool thing to see too.
Does the patient, do they need to have like a consent signed for this if they
Yeah,
need it? Okay.
absolutely. Yep, that is a consentable service. So we always want to make sure that there's a consent involved, that there's informed consent, that they're educated about the procedure beforehand. What else? If the person has a guardian, so if they're somebody who is deemed like not, if they have somebody else who makes healthcare decisions for them, the guardian would be the one to sign the consent. And then I think with nursing, just a big thing is going to be teaching, making sure those consents are signed and teaching, providing education about the therapy. Do you have any other questions about ECT? Is there anything I missed?
So this therapy just basically it shocks the brain in a way.
Yep. Yep.
Okay.
It shocks the brain. It induces a seizure, and it kind of resets the neurotransmitters in the brain to help treat depression, help treat the depressive symptoms.
Okay.
Okay, so back to talking about schizophrenia. Patients with schizophrenia, they may have those extrapyramidal symptoms that we talked about. And so if a patient does have EPS or extrapyramidal symptoms as a side effect of their antipsychotics, we don't necessarily want to stop those antipsychotics, which this is more of a provider type question, but they might say like, you might be asked about it, and what you can do is you can treat the extrapyramidal symptoms with anti-Parkinsonian drugs or benztropine. What else? There's two terms that go along with extrapyramidal symptoms, and I'm probably going to butcher this one, but akathisia, akathisia. Akathisia is the continuous restlessness and fidgeting that comes with extrapyramidal symptoms. And the other term that falls under EPS is dystonia. And dystonia is involuntary muscular movements of the face, arms, legs, and neck.
Okay.
What else do we have? So part of dyskinesia, that is bizarre facial and tongue movements, stiff neck, and difficulty swallowing. And part of dyskinesia is potentially irreversible once somebody does develop that. And then we already talked about the neuroleptic malignant syndrome, which can also, I guess, would be considered like a rare adverse effect of antipsychotic medication, and that is rare but potentially fatal. It involves muscle rigidity, high fever, tachycardia, tachypnea, fluctuations in blood pressure, diaphoresis, rapid deterioration of their mental status, down to stupor and coma. And at that point, we want to discontinue the antipsychotic or neuroleptic medication. So I think in general, just patient education about patients diagnosed with schizophrenia who are taking antipsychotic medication is going to be using caution while driving. Do not stop taking your medication. That is always going to be a really big one with a lot of our psychiatric diagnoses. I mean, I guess in any medication across any health care field in general, but that like adherence to medication is a big difficult thing within mental health, because as the individual waxes and wanes and that he or she feels, that usually causes opportunity for them to stop taking their meds. So we want to always provide medication education and teach them not to stop taking their meds. No smoking, no alcohol, and pregnancy is a big topic, because there are certain medications that people with psychiatric diagnosis can still take while pregnant, but making sure that that they inform their provider if they plan on becoming pregnant, so that we can get them on a medication that is pregnancy safe. So schizophrenia is our psychotic disorder that NCLEX is really going to look at. And then the next bucket is going to be mood disorders. And our mood disorders are going to encapsulate depression and bipolar disorder and anxiety disorders. So first we'll start talking about depression. Depression can range, major depressive disorder can range from mild, moderate to severe, and it involves loss of pleasure in usual activities. There are some predisposing factors to depression, such as genetics, deficiency of norepinephrine, serotonin, and dopamine. And again, kind of having a big life altering or big event in one's life, a trauma, that can also lead to the person experiencing depression. Suicidal ideation or suicidal potential does kind of go hand in hand with depression diagnosis as well. And a big thing with depression in the treatment of depression is that the suicidal potential often increases as the level of depression decreases. Depression, they can be so down that even though they have suicidal ideation, the thought of acting on that suicidal ideation, they're so down that they can't physically act on that suicidal ideation. But as an individual is then being treated for depression and they're starting to feel better, sometimes just that feeling better then enables that person to act on their suicidal ideation. So just because somebody's depressive symptoms are quote unquote improving, that person is still at risk for suicide. Those include, the categories of those are going to be your MAOIs, your TCAs, SSRIs, and your SNRIs. In true clinical practice, we really don't use MAOIs or TCAs too much anymore, but I feel like those are always ones that they're going to ask you on the NCLEX because of all of the food interactions with MAOIs. Did you learn about those? What was that?
I think it's pronounced triamine.
Oh, yeah. So like the thing that's in turkey, tyramine or tyramine or whatever.
Yeah, the MAOIs. I'm like, oh my God, what is that? It wasn't until after my test I had to look that up, and I'm like, oh.
Yeah. Yes. So I swear that question is always on the NCLEX, even though we don't really use MAOIs anymore. But the MAOIs have a ton of, the MAOI with antidepressant medication, they have a ton of food interactions. So make sure you are familiar with them. They include dietary restrictions for a patient taking MAOIs include aged cheeses, raisins, caffeine, red wine, yogurt, avocados, smoked meats, alcohol, soy sauce. Like you said, high in tyramine. These are all foods that patients taking MAOIs cannot eat. Your selective serotonin reuptake inhibitors and your norepinephrine reuptake inhibitors, those are going to be the ones that are in true clinical practice prescribed most often. They block the presynaptic reuptake of the respective neurotransmitter, serotonin and or norepinephrine. So those are going to be your SSRIs are going to be citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. Just be familiar with like the main SSRIs and SNRIs, because I think that these are common medications that can be on the NCLEX, or they'll just kind of say the patient's on this. What teaching would you provide? What else? So like how we talked about the electroconvulsive therapy, that therapy is going to fall under treatment for depression. Some risks of antidepressive medication. Going to be serotonin syndrome. So patients taking SSRIs or SNRIs, or any medication that affects serotonin, they can develop serotonin syndrome. And how you would identify a patient with serotonin syndrome: they may present agitated, confused, have high blood pressure, tachycardia, muscle rigidity, sweating, diarrhea, and headache. And then as that serotonin syndrome worsens, they may develop into having high fever, seizure, cardiac arrhythmias, unconsciousness. And that you can see that, you might see that in a patient who was being treated for depression with like an SSRI or a SNRI, and he or she had suicidal ideation and then decided to take an overdose of their antidepressant. So you also might see serotonin syndrome develop in a person taking antidepressant medication and they're taking it concurrently with opioid pain medications, or at St. John's wort. I don't even know what that is. I know it's a supplement, but I know that question was on my NCLEX. So so teaching patients taking antidepressant medication to not also take St. John's wort. A big piece of nursing education with depression and antidepressant medication is going to be to do not stop taking the medication, because it does take multiple weeks to notice the effects. Again, antidepressant medication can cause weight gain. So I think proactively teaching patients about that or making them aware of that so that they don't just stop taking the medication because they started gaining weight. And some other nursing education points could be that some medications can cause insomnia. Some antidepressant medications can actually cause sleepiness as well. So maybe taking the meds at a different time of day, like if it's a medication that causes insomnia, taking it early in the day, so that it doesn't affect their sleep as much, or if it's a medication that causes sleepiness, to taking it before bedtime. And then sexual dysfunction, that's an important one too, but that is a side effect of some antidepressant medication. Yeah. Special populations that may be treated for depression, to kind of keep at the front of your mind, are the adolescent population. That there's a black box warning on antidepressant medications for adolescents. And for adults, we tell them, oh, make sure you just keep taking it. It's going to take a couple weeks to kick in. Don't stop taking it prematurely. But with adolescents, there's a black box warning on antidepressant meds that says that if an adolescent were to develop suicidal ideation, that we need to stop that medication immediately. There is an increased risk for suicide for adolescents being treated with antidepressant medication. So being aware of that, the elderly population are having do have an increase in depression. Kind of has to do a lot with like the aging process, major life stressors, and they are at increased risk of suicide, and as well as postpartum individuals. Women who are postpartum, they have an increased risk of depression and an increased risk of suicide and infanticide. I don't know how to say that word, but harm to the baby. So those special populations. Any questions pertaining to depression before we move on to bipolar disorder?
No, I think you covered it all.
Okay. So bipolar disorder is another disorder that falls into the mood disorder category. Bipolar disorder are rapid cycles of mania and depression. Mania is when there's an alteration in mood, elation, inflated self-esteem, grandiose, hyperactivity, agitation, accelerated thinking and speaking, decreased need for sleep. The individual experiencing mania might have flight of ideas, distractibility, and an increased affinity for pleasurable activities. So bipolar disorder, they might, if they're in a manic state, they might go on buying sprees or spending sprees, go spend thousands and thousands of dollars on clothes or shoes or whatever. They might be going through like a lot of sexual activity. They might be doing reckless driving down the road while they're in that manic state. So there are two different types of bipolar disorder. There's actually three. I think the two that you're gonna have to differentiate between the two on the NCLEX would be bipolar 1 and bipolar 2. I'm gonna share my screen for a second because I have a really cool visual. Okay. So, do you see the graph on my screen that shows kind of the difference between bipolar 1 in red, where the individual reaches full mania and at like the height of their bipolar, and then the depth of their bipolar disorder can go down to major depression. Do you see the image on my screen?
Yeah.
Okay, so that's bipolar 1. Bipolar 1 is full mania and all the way down to major depression. Bipolar 2 is represented by the yellow line. And as you can see, in a manic state, individuals with bipolar 2, they only reach hypomania. So they don't reach full-on mania. They go hypomania, and then but they still go down. Their depth of their bipolar disorder still goes down to that major depression. And then the third type of bipolar disorder, which I really don't think you'll be tested on, but just for awareness, is cyclothymia. And not to minimize or not to use the wrong words, but this person with cyclothymia, they reach up to hypomania and down to minor depression. So it's a less severe swing. Cyclothymia is a less severe swing between mania and depression, whereas bipolar 1 is going to be the most severe swing, and then bipolar 2 is going to be that in between.
I like this graph. I like it.
Yeah, I liked it too. I honestly remembered seeing it from when I was in nursing school, and so I did a quick Google search and had to make sure I found it because it's kind of hard to differentiate them, in your head. It's kind of in clinical practice too. I feel like it's kind of hard sometimes to discern between bipolar 1 or bipolar 2, to decide what is hypomania or mania, for an individual. Predisposing factors. So some predisposing factors to bipolar disorder are genetics, the neurotransmitters. There's a lot of neurotransmitters that are affected differently with bipolar disorder because the individual experiences kind of two different polar opposites. They experience that depression, and then that mania. So when they're in the depressive depression state, they're having a deficiency of norepinephrine and dopamine. And then when they're in the manic state, they're having excess of norepinephrine and dopamine. They experience low serotonin in both phases, both in depression and mania. And there's possibly an interplay of some acetylcholine and some alterations in the acetylcholine levels that can play into bipolar disorder. Sometimes a patient might be on steroid therapy or something else, like I don't know what somebody might be on steroid therapy for, like rheumatoid arthritis, and then that can precipitate the individual experiencing bipolar disorder. So the treatment for bipolar disorder is going to be mood stabilizers. We want to treat patients with bipolar disorder with a monotherapy mood stabilizer, and they might. I feel like lithium is always a standard question on the NCLEX in regards to bipolar disorder.
Yeah.
Being familiar with lithium and the narrow therapeutic serum levels of lithium, that's always like one question that they'll ask is if the patient has lithium toxicity or not. We can Bipolar disorder can be treated with kind of an array of different medications. So we use like lithium as the anti-manic medication. We can treat individuals with anticonvulsants, valproic acid, gabapentin, clonazepam. We can sometimes the psychiatrist will use some antipsychotic medications like olanzapine, Seroquel. So I wouldn't focus as you're studying or reviewing this. I wouldn't focus too much on what medications to use for bipolar disorder, but more just being familiar with like the different names of the medications and knowing what categories those meds fit into and what side effects might precipitate those meds, and specifically paying attention to lithium because that one's always a question for standardized testing. I feel like. Lithium does pose some risks. There's lithium toxicity. It has a very narrow therapeutic blood serum level. So a patient prescribed lithium is going to need routine lab work. A person taking lithium needs to consume adequate dietary sodium intake and adequate water intake because it's metabolized in the kidney. So we want to optimize your kidney function to make sure that lithium doesn't build up. A person with lithium toxicity might experience blurred vision, ringing in the ears, or tinnitus, nausea, vomiting, diarrhea, tremors, confusion, excessive urine output, nystagmus, seizure, coma, and or myocardial infarction. Any questions about bipolar disorder?
No, I think you covered it all. The biggest med I think is like lithium.
Mm-hmm.
I have that the level is like 0.6 to
1.2.
1.2,
Yep,
and
you got
then
it.
anything greater than 1.5 is considered toxic.
Yep,
Um, let's see, I have that it's contraindicated in pregnancy.
yep.
And then all those symptoms that you just mentioned, I have those as well.
Perfect. Yes. That is good. Having that range, that 0.6 to 1.2, um, having that kind of memorized, especially before you take your test, that's going to be a big one. Um, and then knowing the symptoms of lithium toxicity. I actually have one of those questions on our practice questions that we'll get to in a few minutes here.
Okay, perfect.
So the next category to talk about is going to be anxiety disorders. We'll kind of go over this quickly, but medications for anxiety disorders are going to be your antihistamine medication. Sometimes they provide hydroxyzine or Vistaril for anxiety. They also do prescribe benzodiazepine. That's going to be your alprazolam, clonazepam, diazepam, lorazepam. Those are not first line treatments because those medications can be quite addictive and people can be reliant on those medications in decreasing their anxiety. Our first line treatment for anxiety is going to be antidepressant medication, actually, SSRIs and SNRIs. Those are our first line anti-anxiety treatments. And they can also sometimes they prescribe some beta blocker medication because it blocks beta adrenergic receptor activity for anxiety. Um, so there's a couple different types of medication to treat anxiety disorder. What else? Just a couple terms to talk about that might come up. Panic disorder. These are recurrent panic attacks. The person experiences palpitations, sweating and trembling, shortness of breath, feeling of choking, chest pain, nausea, dizziness. What else? There's a term called agoraphobia,
Mhm.
and that is a panic attack with fear of being in a place or situation where it is too difficult to escape. And
Mhm.
people who have agoraphobia, untreated, they are people who might end up like staying in their house, like where they won't leave their house, they won't go out in public because of that severe fear of not being able to escape a situation. Um, there's generalized anxiety disorder. That is chronic, unrealistic, excessive anxiety and worry for greater than 6 months. Some things with anxiety disorders, some like a nursing assessment pieces that could be asked would be you want to see how much caffeine the person's taking in. And you also want to look at their thyroid function because hyperthyroidism um, can sometimes precipitate these, these anxiety disorders. So we want to look at the thyroid labs as well.
Yeah.
Um, what else? There's trauma and stress related disorders. So this is going to encapsulate your post traumatic stress disorder, your PTSD. Um, PTSD used to fall under anxiety disorders, but in the new DSM 5, they changed it out of anxiety disorders and gave it its own category of trauma and stress related disorder.
Mhm.
So, what else? Some other like vague topics that I could see possibly being on the NCLEX in regards to psych mental health questions would be like human sexuality and gender identity. Um, Making sure you know the difference between like using proper pronouns with an individual, why that's important in therapeutic communication, um, understanding transgenderism and knowing that if somebody identifies, so if somebody identifies as a transgender male, that means that that individual was female gender at birth, but presenting as a male. So, and then if you see the term transgender female, that means male gender at birth, but presenting as female. The transgender population has a high prevalence of depression, anxiety, and suicide. So just doing a comprehensive assessment on these individuals and proactive screening can be really important. And then I have a little bit of info, like I just have like one line about borderline personality disorder.
Mhm.
I don't think you'll ask any questions about that in the NCLEX style testing, but just to know that somebody experiencing borderline personality disorder, that is going to be somebody that's very important for the nurse to set very strict limits with, to have limit setting, to have clear expectations of their behavior, you know, to avoid being manipulated by that individual. That this individual, somebody with borderline personality disorder, they're always in a state of crisis. And they often experience chronic depression, the inability to be alone. Um, they, they can present kind of manipulative to, I mean, to people in their lives, but specifically to like healthcare providers
Yeah.
during their treatment in the hospital. And
Yeah.
they often experienced a lot of childhood trauma. So in your assessment, making sure that you're doing a full assessment and looking at all the different factors that affect that individual.
Okay.
Before we go on to the NCLEX style questions, any questions about those different diagnoses?
No, I think you did a really good job of going over them all. I don't know if you have anything written down on your end, but I did see like a couple of questions pop up about people with depression that have like insomnia and
Mhm.
when would be like a good time, how to like educate someone with insomnia, like if they have like a disturbed sleep pattern, like when you should tell them to like sleep like during the day, exercise before going to sleep. I remember this being like a select all that apply question. I don't know if you have anything on your end about insomnia.
Okay. I've got on my practice questions, I don't have anything in there, but I have the books next to me where I've got some more NCLEX style practice questions. So I will pull from those books and see if there's anything specifically related to insomnia. Okay.
Okay.
Okay, great. Let me share my screen 1 minute. Mhm. All right. Okay. So can you see my very not visually appealing NCLEX psych review PowerPoint?
Yep.
Okay. So I'm a very visual learner. So I like to be able to see the question um as I'm going over it. It helps me comprehend it better. So I figured I would just do it this way so that if you're the same way, so you can see the question written out versus me just like reading a bunch of them out loud.
Okay. Sounds good.
So not trying to be like I don't know, like we're in class right now. It's not supposed to be like that, but I figured just so you could read it yourself kind of. So first question. A client with a diagnosis of depression who has attempted suicide says to the nurse, I should have died. I've always been a failure. Nothing ever goes right for me. Which response by the nurse demonstrates therapeutic communication? Now, I feel like a lot of questions on the NCLEX regarding psychiatric questions are going to have some component of therapeutic communication to it. So we always want to look, I don't know, some guidelines around therapeutic communication are going to be not agreeing with the patient with what he or she is saying. Your response always wants to be kind of open-ended to allow the individual the time and space to elaborate on, what he or she is feeling. You also don't want to like put words in their mouth or like try to make them feel a certain way. That's not therapeutic communication. So, of the answers provided, is there one that you feel like is more therapeutic than the rest? Or is there anyone that that you would eliminate right away?
Definitely two.
So we'll cross that one off.
And then one for sure too.
Correct. Yeah, we don't want to say you have everything to live for because that's kind of like taking away from the way that they're feeling.
Exactly, yeah.
And so another one that I'd like to cross off is number 3, because it's kind of shutting them down in a way, like feeling like this is all part of being depressed. So I think process of elimination, we'll select 4.
Yeah, because that gets them to talk more like about what they're going through and stuff. Like, oh, have you like you've been feeling like this for a while? It tells them like you can get a response from them. Like the other ones are like, no, you can't really get a response from them.
Exactly.
And you should like never ask like why questions either. So
That's correct. Yes, very good. You never want to ask why questions because why is just kind of like it's not getting the person to it's not showing them that you understand what they're saying, and it's also not getting them to elaborate. So you're right. Answer 4. Responding to the feelings expressed by a client is an effective therapeutic communication style. The correct option is an example of the use of restating. The remaining options block communication because they minimize the client's experience. The nurse visits a client at home. The client states, I haven't slept at all the last couple of nights. Which response by the nurse demonstrates therapeutic communication?
3 for sure.
3 for sure. Yep, you are right. Answer 3. It's using that restating. So even in situations where a patient is saying something like very bizarre and something you don't agree with, like let's say a patient's saying like, I don't know, oh, the FBI is stalking me and they've microchipped my brain. Um, so restating can be used in those kind of situations as well because you're not agreeing with the person. You're not saying, "Oh, yep, you're totally right," but if you restate what they have said to you, um, it can help build trust and confidence with that person, and so that they'll feel comfortable to continue speaking with you. But you're also not agreeing with them and giving them like a false sense of like agreement that what they're about their delusions. A client experiencing disturbed thought processes believes that his food is being poisoned. Which communication technique should the nurse use to encourage the client to eat? Using open-ended questions in silence, sharing personal preference regarding food choices, documenting reasons why the client does not want to eat, or offering opinions about necessity of adequate nutrition.
One.
That's good. Yeah. So um, so if we like just look at the question without even knowing like anything about the exact situation. We know that the question says which communication technique. So number 3 says documenting reasons why the client does not want to eat. That's not a communication technique. So we can take that one off the bat right from the start. Sharing personal preferences, that's not really a communication technique either. And then, so that really leaves us 1 and 4, where 1 is actually talking about communication techniques, and 4 is more opinions, which we know are not always the best in communication. So yeah, answer 1. On review of a client's oh, you know what? We didn't talk about this. Do you know the difference between voluntary and involuntary admission in an inpatient behavioral health situation?
Involuntary is like, so I'm trying to remember. So I used to be like a patient sitter, and if they're like involuntary, they're like a threat to society.
Mm-hmm.
And they, and then voluntary is they're just coming in saying that they feel like suicidal and that they want to help, whereas like involuntary would be like they tried to kill themselves or they tried to kill someone else, I think.
Yeah, so voluntary versus involuntary, when it comes to psychiatric situations, voluntary means that the person is there on their own free will. So they say, I recognize I have a problem and I need to receive treatment for this problem. Involuntary is going to be individuals who have like a petition and certification filled out on them, and they had some sort of event happen prior that precipitated them being hospitalized, that the pit insert will state that they are a danger to themselves or a danger to others. And they are then hospitalized involuntarily, or, against their will. And when somebody is hospitalized involuntarily, they're also like not allowed to just leave the hospital whenever they want, so there's certain like rules and regulations around voluntary versus involuntary admissions. So looking back at this question, on review of a client's record, the nurse notes that the admission was voluntary. Based on this information, the nurse plans care anticipating which client behavior. So we know that the client is voluntary. So we know that he or she is recognizing that they need help and that they need treatment, and is there receiving mental health treatment on their own accord. So we want to look at what the nurse plans care anticipating which client behavior. Number 1, fearfulness regarding treatment measures. Number 2, anger and aggressiveness directed to others. 3, an understanding of the pathology and symptoms of the diagnosis. Number 4, a willingness to participate in the planning of the care and treatment plan.
Yeah, 4.
4 for sure. So 1 and 2 are going to be more of your involuntary patient. 3, just kind of, I don't know. I mean, you can't really anticipate if the patient's going to understand the pathology of his or her symptoms. But 4, we can say if somebody's voluntary, they're probably willing to participate. Next question. When reviewing the admission assessment, the nurse notes that a client was admitted to the mental health unit involuntarily. Based on this type of admission, the nurse should provide which intervention for the client? 1, monitor closely for harm to self or others. 2, assist in completing an application for admission. 3, supply the client with written information about his mental health problem. Or 4, provide an opportunity for the family to discuss why they felt the admission was needed. I feel like this question is kind of tricky. So the answer is 1. And The reason being, kind of like you said, those involuntary admissions, those are usually because the person is at risk for harm to self or others. So this is one of those questions where we are going to prioritize safety as the nursing priority. Yes, I mean, the nurse might assist in completing an application for admission, but that's not really the priority in the situation. Yes, the nurse might supply the client with written information about his mental health problem, but that's also not really the priority in this situation. And four, although four might be the case, like the family might have petitioned the patient. It also might not have been the family. Like it could have been the police. It could have been anybody who filled out the petition to make the patient have to be admitted involuntarily. Do you have any questions on this one? I felt like this one was kind of, I don't know, kind of tricky.
No, like you said, it was like this one like strictly focuses on safety.
Okay. What is the most appropriate nursing action to help manage a manic client who is monopolizing a group therapy session? You can ask the client to leave the group for this session only. You can refer the client to another group that includes other manic clients. Tell the client to stop monopolizing in a firm but compassionate manner. Or thank the client for the input, but inform the client that others now need a chance to contribute.
I feel like I saw this question on my test. I mean, yeah, what is the mode to managing manic client? So he's like currently manic, like in a manic episode.
Yep, in a manic episode, and we're in a group therapy setting with other patients, and this person's kind of monopolizing the therapy.
I mean, I would go with one. I don't know. This one's hard, I think.
This one is hard. This one's very situational too, because you don't exactly know like what is this person doing that's monopolizing the group therapy session.
Right.
Is he or she like saying inappropriate things or not, or whatnot? So let's see what the answer is. Okay, so it says answer 4. If the client is monopolizing the group, the nurse must be directive and decisive. The best action is to thank the client and suggest that the client stop talking to try listening to others. So I think even though I still think 1 is correct, but I think 4 is more correct. Like I think
4 is like more NCLEX correct, like
yes,
more open, more like yay, like we still love you, but please.
Exactly. You got it. So I feel like in this situation, 4 is going to be what you would do first. Thank you for your input, but we're going to give the other people a chance to contribute. And then if the patient still monopolizes the group therapy session, then we're going to go to number 1. Now it's time for you to leave the group. You can come back later if you can contain yourself and let others participate. Okay. The client says to the nurse, "The federal guards were sent to kill me." Which is the best response by the nurse to address the client's concern? Number 1, I don't believe this is true. Number 2, the guards are not out to kill you. Number 3, do you feel afraid that people are trying to hurt you? Number 4, what makes you think the guards were sent to hurt you?
Um, 4.
What makes you think the guards were sent to hurt you?
4
Agree.
3, yeah.
I agree. I feel like 1 and 2 we can kind of cross off. Like we know that those are not very therapeutic. 3 and 4 are kind of probing further to the patient, right? Like trying to get more information out and trying to get to the bottom of
Like 3 is more close-ended, and then 4 is more open.
Agree. Yes, I agree. Because 3 is kind of like a yes or no. Like the client would respond yes or no, and that's not really getting them to talk more. But 4 is giving them the opportunity to expand. So let's see. Dang it. Well, it says it's answer 3. The reason is it is the most therapeutic for the nurse to, I said that wrong, to empathize with the client's experience. Disagreeing with the delusions may make the client defensive. Encouraging discussion regarding the delusion is appropriate. Makes you think. I mean, this one was tricky. So if I was giving the NCLEX, I feel like 3 or 4 would be appropriate.
Right, yeah.
The only thing I could see is maybe how it says what makes you think the guards were sent to hurt you. Maybe it perceives this part, the part of the guards being sent to hurt you, as agreeing with that person.
I was thinking that too.
I'm
Like
not
you're
sure.
more into like the fact that guards were sent to, I don't know.
Mm-hmm.
Okay.
That one's tricky.
Yes.
um, okay, 4. This one. A client is admitted to the mental health unit with a diagnosis of depression. The nurse should develop a plan of care for the client that includes which intervention?
Okay.
Encouraging quiet reading and writing for the first few days. Identification of physical activities that will provide exercise. No socializing activities until the client asks to participate in milieu. Do you know what milieu is?
No, I don't, but I feel like I've seen it before.
Yeah, so milieu is milieu therapy. It's kind of like community therapy in a way. So on an inpatient psychiatric unit, we use the concept of milieu. It's kind of like the patient mix and like your peer mix or the community of patients in the inpatient psych unit. So milieu is kind of like the interactions of the group, the interactions of the other patients on the unit or this and how the staff interplay in there. So you might see that word milieu on your test in questions. And that's really just what it means. It means like in the group of inpatient behavioral health is what milieu is.
Okay.
And then 4, a structured program of activities in which the client can participate.
Yeah, I would say what 4.
I agree. A client with depression is often withdrawn while experiencing difficulty concentrating, loss of interest or pleasure, low energy, fatigue, and feelings of worthlessness and poor self-esteem. So these first 3 really are not helping the person with depression. They're kind of going along with what that person wants to do, like be reclusive, do quiet reading, no socializing events. This identification of physical activities that will provide exercise, I mean, that's great in theory and all, but that might not be like individualized for the client. So
Yeah.
providing a structured program of activities, that's a big thing in psych mental health is going to be providing structure to the individual. When planning the discharge of a client with chronic anxiety, which is the most appropriate maintenance goal? Suppressing feelings of anxiety, identifying anxiety-producing situations, continuing contact with a crisis counselor, or eliminating all anxiety from daily situations.
I would say 2.
2, definitely 2. We want the client the patient to be able to identify what situations may cause anxiety,
Yeah.
and then be aware of that ahead of time, and then make the choice to either still proceed with introducing themselves to those situations, or maybe not going to an area full of a bunch of people because that's what causes them anxiety. The nurse is conducting a group therapy session. During the session, a client diagnosed with mania consistently disrupts the group's interactions. Which intervention should the nurse initially implement? 1, setting limits on the client's behavior. 2, asking the client to leave the group session. 3, asking another nurse to escort the client out of the group session. Or 4, telling the client that they will not be able to attend any future group sessions.
Okay, so definitely not 4.
Definitely not 4.
Ask the client. So I would go with 1.
I would go with 1 too. I think that the answer to this one is not 1. Oh, it is. It is. Okay, good. So I wasn't sure if this one, I couldn't remember. But yes, we want to initially set limits on the client's behavior. So 1 is going to be our first step. And then our second step, if we set those limits and the client still did not listen to those limits, then we would then we would do number 2, ask the client to leave the group session. Very good. A manic client begins to make sexual advances towards visitors in the day room. But man, I keep spelling nurse wrong in this. I'm so sorry. When the nurse firmly states that this is inappropriate and will not be allowed, the client becomes verbally abusive and threatens physical violence to the nurse. Based on the analysis of the situation, which intervention should the nurse implement? 1, place the client in seclusion for 30 minutes. 2, tell the client that the behavior is inappropriate. 3, escort the client to their room with the assistance of other staff. Or 4, tell the client that their telephone privileges are revoked for 24 hours.
I would go with 3.
Definitely. This is the one I was thinking of earlier when I got confused about it. But yes, 3. So we've already tried number 2, we already tried, right? The nurse already firmly stated that this is inappropriate and will not be allowed. And then the patient is continuing to escalate. So doing number 2 is not going to help. 3 helps us maintain safety. We're going to escort the client to their room. We're going to have other staff present so we're not putting ourselves in a dangerous situation. And that will be what's safest for the client and for the others around, especially when that individual has expressed made some violent remarks or made some, I forget what the question said, but it like the patient was threatening violence. So we need to just get them out of that situation.
Yeah.
The nurse observes that a client is pacing, agitated, and presenting aggressive gestures. The client's speech pattern is rapid and affect is belligerent. Based on these observations, which is the nurse's immediate priority of care? So we've got a patient who's having a lot of positive symptoms, possibly almost on the verge of being aggressive or showing violence. What does the nurse need to do?
I would go with 1.
Provide safety for the client and other clients on the unit. Yes, you are right. The other ones don't really address the other clients on the unit, and that we need to make sure that everybody's safe. That is what our priority is. The nurse is preparing a client with schizophrenia, a history of command hallucinations for discharge by providing instructions on interventions for managing hallucinations and anxiety. Which statement in response to these instructions suggests to the nurse that the client has a need for additional information? So we've got a patient who's discharging, patient has schizophrenia and has hallucinations. And the patient's going to say something that makes the nurse think that we need to do better teaching.
Okay.
My medications will help my anxious feelings. I'll go to support group and talk about what I'm feeling. When I have command hallucinations, I'll call a friend for help. And 4, I need to get enough sleep and eat well to prevent feeling anxious.
Yeah, I would go with 3.
Yes, because the other ones are like all good things, right?
Yeah.
Like, yes, we want the person to eat and sleep well. We want them to take their medications and we want them to go to support group. But I think the thing about 3 is that command hallucinations, those, when somebody has command hallucinations, those are very risky, because the command hallucinations could tell the person something, very detrimental. Like they could say, you should kill yourself, or
Yeah.
you should kill that person walking down the street. And so calling a friend for help is not who we want them to call. We want them to seek like immediate healthcare professional help at that point.
Yeah.
Yeah,
Like they could harm their friend because like they're probably not on their meds or something. So they can like harm the friend if they call them.
exactly. Good job. The nurse is caring for a client just admitted to the mental health unit diagnosed with catatonic stupor. The client is lying in the bed in the fetal position. Which is the most appropriate nursing intervention? Ask direct questions to encourage talking. Leave the client alone to minimize external stimuli. Sit beside the client in silence with simple, open-ended questions. Or talk to the client in the day room with the other clients to provide stimulation.
So is this like one of like the negative symptoms?
Mm-hmm. Yep. Catatonic stupor. That's going to be basically like somebody who's completely still, not moving their body and kind of just staring at into space, like not seemingly looking at anything, just staring off.
Okay. Let's see. Ask direct questions to encourage talking. Okay. Leave the client alone. So that's to minimize external stimuli. Sit best. Okay. Talk. I would go with 3, I think.
Awesome. Yep, 3 is the answer to this one. And this one I think it's kind of tricky because, like, yes, asking direct questions, number one, it might work. But I think 3 kind of gives that sit beside the client in silence with simple open-ended questions. It gives that therapeutic presence. Whereas the other ones are kind of like 2 and 4. 2 is obviously not the answer. That one's just like, oh, just leave the client alone. That's not gonna help us get, the information we need from the client. And then 4, I don't think putting the client in the day room where everybody else is, like, that's not gonna help the client speak either. But 3 kind of gives that therapeutic nursing aspect to it. So good job on that. So communication with withdrawn clients requires much patience from, man, to be honest, I typed this last night pretty late, so I do apologize for all my spelling errors.
Oh, that's okay.
Okay, this one. The nurse is caring for a client diagnosed with paranoid personality disorder who is experiencing disturbed thought processes. In formulating a nursing plan of care, which best intervention should the nurse include? 1, increase socialization of the client with 2, avoid using a whisper voice in front of the client. 3, begin to educate the client about social supports in the community. 4, have the client sign a release of information to appropriate parties for assessment purposes. So we've got a patient who's paranoid and is currently experiencing disturbed thought processes. So they're a pretty critical patient. You're the nurse for the day. You're trying to make a plan of care. What is your most important intervention? So I think this one's kind of tricky. I think that 3 is not right, because a patient who's experiencing disturbed thought processes in that moment is not going to be ready for education about social supports in the community, right? This person's like pretty unwell at this point, so 3 is probably not right.
Yeah, that's more like a long-term thing.
Absolutely.
For the client release and have the client sign a release of it. I mean, I don't think they're in like the right state of mind to sign something.
That's right. So I would take number 4 away too.
Avoid using a whisper voice in front of the client. I mean, it doesn't really, like, why would a nurse use a whisper voice in general?
That is a good question. um, and
I've
then
never seen a nurse use a whisper voice in general. It's always like a like a very high.
very direct, very loud voice. This is true.
So I think the best one is one out of all of the four, but I mean, even that one kind of is,
Not super great, right?
but I think out of the four, oh, two, really.
Okay, so I think what this question was trying to get at is the paranoia part of it and what the patient was experiencing with the paranoia and how whispering um, can exacerbate that. Um, but I mean,
Wait, let me see that the rationale again.
yes,
Disturbed
disturbed thought process related to paranoid personality disorder is the client's problem, and the plan of care must address this problem. The client is distrustful and suspicious of others. The members of the healthcare team need to establish rapport and trust with the client. Laughing or whispering in front of the client would be counterproductive.
okay, yeah, so maybe like you don't want to like trigger anything. So, yeah.
Okay. So maybe it's trying to say that at this point, the patient would not be number one. The patient wouldn't be ready for number one yet, is maybe
Yeah.
what this was trying to get at.
Okay.
Hey, Melissa, how are we on time? Are we doing okay, or what time? I see it's 12:34. I wasn't sure how long this was allowed to go today. Let me pull up my thing just to make sure I'm not going into another meeting.
That's totally up to you, Kaylin and Mary. I have it. You guys just whatever you want to do, it can keep running. But I had only scheduled it till 12:30.
Okay. I'm available to keep going. Mary, no pressure. If you are available, we can keep going. And if not, I can send all these questions with the rationale to you if that would be helpful.
No, I mean, I don't mind. It's up to you. If you have something, then I can like you can send me this and then I can ask you for any questions or anything. Um but I know you have like a daughter and stuff.
Oh gosh, no, I'm fine. She's sleeping in my arms right now. So
Oh.
if we want to continue, I am totally great with continuing. And then if we need to, let's just look at, I don't know, let's say we'll continue for another 15, 20 minutes. And if we still don't finish the questions, if these questions are helpful to you, I can send them to you. Okay.
Okay, sounds good.
All right. Perfect. Okay. So this question, the nurse is planning activities for a client diagnosed with bipolar disorder with aggressive social behavior. Which activity would be most appropriate for this client?
Oh God, I think this was like literally on my test.
Well,
I think I'm
I
really
mean,
sure
that's good. Then it means the practice questions are like pretty well tied to the actual NCLEX questions.
yeah, these remind me of like those like nutrition questions.
Yes, yes.
The new
So the patient's has aggressive social behavior. So I think you should probably try to avoid social.
yeah, like group
Yes. So is there any activity listed that is like a solo activity?
writing.
Let's see if that's yes. So solitary activities that require short attention span with mild physical exertion are the most appropriate activities for a client who is exhibiting aggressive behavior. Writing, walks with staff, and finger painting are activities that minimize stimuli and provide constructive release of tension. Next question. The nurse is preparing to perform an admission assessment on a client with a diagnosis of bulimia nervosa. Which assessment findings should the nurse expect to note? Select all that apply. So bulimia is the binge and purge eating disorder. So somebody who would probably like eat a lot of food in front of people and then vomit, self-induced vomiting afterwards.
Okay. Body weight well below ideal range. So 5 is they can have like be overweight or underweight, I think. So
Yeah, you're right.
so I don't think it's 5. Probably 4 would be right because they're vomiting.
Yep.
3 as well.
Yep.
Moist, oily skin. I would say they would have dry skin.
Correct.
And then 1, yeah.
Yep.
1,
Very
3,
good.
and 4, I think.
1, 3, and 4. That is correct. I think another identifier too, because 5 kind of tripped me up because I was like, well, body weight well below ideal range, like it could be, but I think when questions are presented this way and they use like a definitive term, like well below ideal range, like that, I think that's an indicator that that question, that this answer is trying to trick us and that it's probably not right. You know, if because it says well below ideal range, it doesn't just say body weight below ideal range.
Yeah.
Using that like descriptive word in there,
Yeah.
it's trying to be tricky. So 1, 3, and 4 is correct. Clients with bulimia nervosa initially may not appear to be physically or emotionally ill. They're often at or slightly below ideal weight. On further inspection, a client exhibits dental decay and loss of tooth enamel if the client has been induced vomiting, and electrolyte imbalances are present. And you are correct about the dry scale. They typically have dry or scaly skin, not moist, oily skin. The nurse is assessing a client who was admitted 24 hours ago for a fractured humerus. Which finding should alert the nurse? I don't know what I was trying to type there, but to look at alcohol withdrawal delirium. So we've got somebody with a fractured humerus, and what symptoms below would indicate that the patient is in alcohol withdrawal delirium?
Hypotension, of course. I think like they're more in a like seizure symptoms, I would say.
Mm-hmm.
Like delirium, like they get the tremors. So
Yep.
I'm looking at 3, but
Okay.
then the lethargy
Mm-hmm.
is kind of tripping me off because I don't know if they would feel that way. They'd feel more like hyper.
Yes,
Mhm.
correct. And typically people going through alcohol withdrawal, they typically have a higher blood pressure, just due to everything going on internally with that withdrawal and with the delirium. Their blood pressure is usually high, so they have high blood pressure. They are, like you said, not lethargic, like the opposite of lethargic. Like they're more hyperactive, and they do experience hallucinations or see or hear things that aren't there. And they also, on top of that, people going through alcohol withdrawal, they get sweaty, they get tachycardic, diaphoresis. Those, they're kind of like all of those like upper type of symptoms.
Yeah, I would say 4. Then.
4.
Yeah.
Answer 4. Symptoms of alcohol withdrawal delirium typically include anxiety, insomnia, anorexia, hypertension, disorientation, hallucinations, changes in level of consciousness, agitation, fever, and delusions. Very good. The nurse observes that a client with potential for violence is agitated, pacing up and down the hallway, and making aggressive and belligerent gestures at other clients. Which statement would be most appropriate to make to this client? 1, you need to stop that behavior right now. 2, You will need to be placed in seclusion. 3, you seem restless. Tell me what's happening. 4, you will need to be restrained if you do not change your behavior.
3.
Yes, definitely 3. So we want, even though this patient is potentially nearing, needing restraints, there are potential for violence, they're agitated, they're pacing up and down the halls, and they're making threats to other people. This is one of those ones where we always want to go with the least invasive intervention first. And that's going to be talking to the client. You seem restless. Tell me what's happening, and seeing if we can get to de-escalate them with that statement. Next question. The nurse is conducting an initial assessment of a client in crisis. When assessing the client's perception of the precipitating event that led to the crisis, what is the most appropriate question? So, with whom do you live? Who is available to help you? What leads you to seek help now? What do you usually do to feel better?
Who leads you to speak now? I think I'm gonna go with 3 for this one.
So yeah, what is leading you to seek help now? Okay, let's see that one. I'm like struggling to read that one, but yes, answer 3. You want to assess the individual or family and the problem. The more clearly the problem can be defined, the better the chance a solution can be found. So very good. Question. A depressed client on an inpatient unit says to the nurse, "My family would be better off without me." Which is the nurse's best response? 1, have you talked to your family about this? 2, everyone feels this way when they are depressed. 3, you will feel better once your medication begins to work. 4, you sound very upset. Are you thinking of hurting yourself? We can eliminate 2, right?
2 and 3, yeah.
2 and 3. So we're kind of down to 1 and 4, which are both decent answers.
Yeah. I feel like you would say 1 after the other. Like this is like a full response. But I think 1 is better because it's addressing like what he just said, and then 4 is saying like, but then 4 is like focusing on like safety but
right.
I think 1 is better. I think, I don't know. I'm gonna go with 1.
Let's see what it says. Okay,
Oh.
so it's answer 4. Clients who are depressed may be at risk for suicide. It is critical for the nurse to assess suicidal ideation and plan. The nurse should ask the client directly about a plan for self-harm. So I see where they're coming at, and I also see, your reasoning on that. Like you said, I feel like those both 1 and 4 would be like asked sequentially after each other if you were interviewing this patient. But you did bring up that before we even knew what the answer was, you did bring up that maybe 4 was getting at a safety point. So I think.
And you did mention that earlier with like depressive disorder, you want to look out for like suicidal ideation.
Yes, that's a big risk with that population.
Okay, sounds good.
Question, which behavior observed indicates a suspicion that a depressed adolescent client may be suicidal?
Okay.
So we're looking for a behavior that there's an adolescent who's depressed, and we're trying to see something that they do that makes us think that they are suicidal. The adolescent gives away a DVD and cherished autographed picture of a performer. The adolescent runs out of the therapy group swearing at the group leader.
Mm-hmm.
The adolescent becomes angry while speaking on the telephone and slams down the receiver. The adolescent gets angry with her roommate when the roommate borrows her clothes without asking.
I'm gonna go with 1 for this one.
Perfect. Yes, 1 is correct. And I think a good way to discern this one is number 3 and 4 both use the emotion or descriptor of angry. So we know that anger doesn't necessarily equate to suicide, right?
Right.
2 is just showing like the adolescent runs out of the therapy group swearing at the group leader. That, like, okay, that something could have happened in therapy that upset them. That doesn't necessarily indicate suicide, but this pattern of giving things away, especially things that are cherished, that is a precursor to suicide, that somebody might be having suicidal ideation. Next question. The police arrive at the ED with a client who has lacerated both wrists. What is the initial nursing action? 1, administer anti-anxiety medication. 2, assess and treat the wound sites. 3, secure and record a detailed history. Or 4, encourage and assist the client to ventilate.
I'm going to go with 2.
Perfect. Yep. This is one of those priority questions. So we just want to treat the, the bleeding wrists, get those taken care of, and then we'll go on to number 4 and number 1 and number 3.
Yeah. And, that's like a thing with being in patient psych. Like you want to make sure like they're medically clear before getting into like their psych, like their feelings and therapy and all of that, right?
100%. Absolutely. We have to make sure patients are medically cleared before they, before we can go to that next step of delving into the psychiatric stuff. Okay, so now we have some medication questions. Now, did you say that you had a lot of these or did not have a lot of these on your test, if you remember?
Let me think. I think I saw lithium on my test, I think. What else? Like thiam, like with someone that's with has like alcohol withdrawals and stuff, like psychosis. It was like vitamin B.
Yep.
B6 or B1. I don't know which one it was. That they're missing that component, and to get that component, I think it's like Ward-Closs syndrome. I saw that on there. So I did see a couple medications, not as much as I like anticipated.
Perfect. Well, we can go through some of these. We can stop. I put a couple of them on here. So we'll start at them, and if you feel like they're getting redundant, we can stop with them, okay?
Okay.
A client's medication history contains a prescription for sertraline. To ensure safe administration of this medication, how should the nurse administer the dose? 1, on an empty stomach. 2, at the same time each evening. 3, evenly spaced around the clock. Or 4, as needed when the client complains of depression.
So not 4.
Not 4, correct.
Evenly spaced around the clock. I wouldn't say 3 either. So.
Yep. Good job.
Same time each evening. On an empty stomach. I think 2.
2, you're right.
Okay.
That medication is administered once a day. It's important to take it at the same time every day. And with that medication, evening administration may be preferred because it can kind of make you a little drowsy. A client with schizophrenia has been started on medication therapy with clozapine. The nurse should assess the results of which laboratory study to monitor for adverse effects. So clozapine is one of our antipsychotic medications. This one's probably kind of tricky. Does this sound familiar to you or no?
Yeah, it does. I think I'm gonna go with 4.
Awesome, good job. Clozapine may cause agranulocytosis. This can be fatal if undetected and untreated. So that's like a very, very low white blood cell count.
Yeah, I think when someone's on this med, they're at an increased risk for infection.
Yes, very good. That. I could see another question being like stemming from something like that. A client is scheduled for discharge and will be taking phenobarbital for an extended period. The nurse should place highest priority on teaching the client which point that directly relates to client safety. So somebody's taking phenobarb. Should they take the medication only with meals? Should they take the medication at the same time each day? Should they use the dose container to help prevent missed doses? Or should they avoid drinking alcohol while taking this medication?
4.
Yes. Yep. So phenobarb is a CNS depressant, and so is alcohol. So we don't want to further bring down that central nervous system. The nurse is describing the medication side effects and adverse effects to a client who is taking amitriptyline. Which information should the nurse incorporate in the discussion? Consume a low fiber diet, increase fluids and bulk in the diet, rest if the heart begins to beat rapidly, or walk if you have difficulty urinating because this is a normal side effect.
I would not go with 4.
Yes. If anybody's having difficulty urinating, we would want them to report that to their healthcare provider.
Right. Let's see. Rest if the heart begins to beat rapidly. Rest. Okay. I don't know. 3 and 2 increase fluids in bulk. What's bulk in the diet? What does that mean?
Fiber. Increase fluids and fiber in the diet. So this medication, I'll give you this other piece of information that you may not know. This medication causes anticholinergic effects.
Yeah. So I think I'm gonna go with like 2.
2. Yep. It causes constipation, and the client is instructed to increase fluid intake and bulk or high fiber in the diet. The nurse is administering risperidone to a client with schizophrenia who is scheduled to be discharged. Before discharge, which instructions should the nurse provide to the patient? Get adequate sunlight, continue driving as usual, avoid foods rich in potassium, or get up slowly when changing positions.
Okay, I wouldn't say 2. No, not that one.
Right.
Get adequate sunlight. I don't think it's 1 either.
Mm-hmm.
Get up slow. I feel like 4 is more for like cardiac drugs.
Mm-hmm.
So I'm gonna go with 3.
All right, let's see. Okay, so the answer is 4, just because this medication does have a side effect of orthostatic hypotension. With this medication, sunlight should be avoided and caution should be taken while driving. So that 3 was just a goofy distractor question, but it got us in this one.
Okay. But like, why not? I think with getting up slowly when changing positions is like, why not?
Right.
Sure.
Very valid point.
Okay.
The nurse notes that a client with schizophrenia and receiving the antipsychotic medication is moving her mouth, protruding her tongue, and grimacing as she watches television. The nurse determines that the client is experiencing which medication combination.
I think 2.
Yep, it is 2. Tardive dyskinesia can occur from antipsychotic medication. Parkinsonism is characterized by tremors, mask-like faces, rigidity, and shuffling gait. Your hypertensive crisis that's on here, that one is going to be more of a risk with those MAOIs.
Mm-hmm.
And the number 4 on here, the neuroleptic malignant syndrome, that is going to be characterized by dyspnea, irregular pulse, fever, blood pressure changes, increased skeletal muscle rigidity. I think this one could have been tricky between 1 or 2 because they're 1 and 2 are both like goofy movements,
Mm-hmm.
like abnormal movements, but knowing the difference between Parkinsonism and tardive dyskinesia, and that tardive dyskinesia really affects the face, whereas
Yeah.
Parkinsonism is more characterized by like arm and leg things, tremors and shuffling gait.
Yeah.
The nurse is performing follow-up teaching session with a client discharged 1 month ago. The client is taking fluoxetine. Which information would be important for the nurse to obtain during this client visit regarding the side and adverse effects of medication?
Fluoxetine. I would say 3.
Problems with mouth dryness. I think that's a really great guess because a lot of these medications have anticholinergic effects, don't they?
Yeah.
So let's see. I don't even know the answer to this one. It's 2. So this one causes nausea, vomiting, cramping, and diarrhea.
Okay.
I learned something new.
Yeah, me too.
The client has been taking Buspar for 1 month and returns to the clinic for a follow-up assessment. The nurse determines that the medication is effective if the absence of which manifestation has occurred. So basically, we're looking for the Buspar working, like something that the patient experienced that they don't experience anymore because they've been taking the Buspar.
Okay. So just going back on that med, is that the, I think that's for depression, if I'm not mistaken, or?
So Buspar can be, oh, sorry, 1 second. My boss is texting me. Let me just read this really quick. Make sure everything's okay. We have
Okay.
to rush. Uh-oh. Okay. Buspar is, so Buspar can be used for anxiety. And can be used as to like treat anxiety.
Okay, so then I think 2.
Yep, Buspar is not recommended for the treatment of paranoid thought disorders, drug or alcohol withdrawal, or schizophrenia. Busparone is most often is indicated for the treatment of anxiety. Here we go. A client taking lithium reports vomiting, abdominal pain, diarrhea, blurred vision, ringing in the ears, and tremors. The lithium level is 2.5 milliequivalents per liter. The nurse plans care based on which representation of this level. Is it toxic, normal, slightly above normal, or is it excessively below normal?
Toxic.
Toxic. Very good. And what were our limits again?
It was like 0.6 to 1.2.
Very good.
Awesome. Well, Kaylin, I think you're good.
That's
Oh, is that done? Really?
Yes.
Wow, great.
Perfect. Thank you so much for like chatting with me today and going through this stuff with me. If you feel like you need more or would like any additional information on any psychiatric process, any extra NCLEX style questions, anything like that, please let me know and I can prepare that and send that your way, okay?
Okay, thank you so much to you. I really liked these questions. They really helped. And thank you so much, Kaylin. I know it's really tough for your job right now, too. I think at one point they were saying there are more psych patients than COVID.
Yeah, we are popping, we are full. And I feel like they kind of go hand in hand. So I think with the pandemic, there's a lot of mental health, downstream mental health things that have come from that. So
yeah, keep it up. And thank you so much.
thank you, Mary. Thank you. Thank you. All right, you guys, I hope you all have a great day today. And Mary, again, reach out if you need anything else or need some clarification on anything or want some more questions. Okay.
Okay, thank you. Sounds good.
Thanks. Have a good one.
Thank you. Hey, Melissa.